This is a routine trans conjunctival manual small incision cataract surgery. Initially, you can see me doing the incision with my sharp end of the crescent knife. I have gone through the conjunctiva. There is no conjunctival dissection. I then turn around the crescent blade and start doing my sclerocorneal dissection very carefully. I first need to get a plane and then extend. The assistant keeps irrigating that area of dissection to wash away the blood so that I can visualize the dissection properly. This whole part of the wound construction is completely unedited so that the viewer can discern each and every minute step that I am doing here, how I am going about performing the incision. Sometimes you will have to keep the patient in position in between and watch the movements of my blade. I go sidewards and backwards most of the time. Very rarely do I try to go forwards. Forward movement is always at the risk of entering prematurely into the anterior chamber. Just go slightly forward. Most of your movements are sideways and backwards. And I have done the scleral pockets as well. Once the incision has been dissected, I go ahead to my side port and enter into the anterior chamber with my cataract1. I will not extend at this point in time. I then stain the capsule with trypan blue. It's a pretty intumescent cataract. I express the trypan blue and the air with 2% HPMC, and my plan is to make a double excess here. Now, as soon as I punctured the capsule, there is no egress of cortex, so I thought I can make a bigger excess, and then the egress started. So I decided not to take a chance. I made a mid-sized excess. I will still go ahead with my plan of a double excess. It's pretty intumescent, and there is a very high chance that it can turn into the flag sign. So there is no point in taking risks, especially this patient is a one-eyed. Once the rexus has been done, mini rexus, I go ahead with my Simcoe cannula and start aspirating the free cortex, and especially the cortex in the equatorial area. The idea is to break the equatorial block and watch. As I am aspirating, I keep nudging and rotating the nucleus, and this brings more and more free cortex to my port. Also, it tells me that the block has been broken. So, just keep on. Some more free cortex is there, take it out. Then put in some HPMC, and this rexus is definitely not enough to express the nucleus. So I just increase the incision slightly. Just watch, not increasing it completely. I make a nick with my micro scissors on the left side. Take my Uthrata and extend the rexus all around the margin. And although this rexus looks adequate, I'm not taking any chances. As I already mentioned, he's a one-eyed. I make another nick, and this time with my micro rexus forceps, I extend it superiorly as well. And that definitely is an adequate rexus. I now extend the incision completely. I open up the incision completely with my keratome. It's time to take out the nucleus. Then under HPMC, I use 2 dialers, and with the sandwich method, just pluck it out of the eye, literally. and there's the nucleus. And then the rest is pretty routine, just to be a little careful and aspirate all the cortex. There will be some very stubborn cortex in such cases. Just have some patience and slowly, but not aggressively, take it out. These are very progressed cataracts and the zonules could be weak, so don't be very aggressive in these cases. Just making sure I get out everything. And once the bag is clean, I put in HPMC and I implant a single piece PMMA lens directly into the bag, all at one go. First the leading haptic goes into the bag, then I catch the trailing haptic, pronate my hand and let go into the bag. Finally aspirate all the HPMC, hydrate my wound, perform the bounce test and conclude the surgery. Thank you for watching.